Well, good afternoon. Sorry for the delay. My name is Jim Yeager. I'm the Senior Academic Dean in the school, and I'm standing in for Dean Clegg, who's away in a meeting in Washington, D.C. And I want to welcome you all to the 6th George G. Graham Lecture. This is a wonderful event that we have each year. And the lectureship started through the Graham Endowed Professorship Fund, and then was endowed by the Middendorf Foundation in 2008, and we're really grateful for that initial support of this lectureship. And then we're really excited this year because we have a new benefactor, and that's the International Child Nutrition Fund, and this is represented by Dr. Bill McLean, who's a former faculty member in the program in human nutrition, and who was a co-investigator with Dr. Graham in the 70s to the early 90s, and also Mr. Alec Graham, the son of Professor Graham. Also, we're delighted to add for the first time Dr. and Mrs. T.C. and Lee Wu. They're in the Johns Hopkins School of Medicine and Public Health, and they are also benefactors for this lectureship. The support of the lectureship in human nutrition really provides our academic community with an opportunity for enrichment every year, and we've been fortunate to always be able to invite a real dynamic speaker who has really been important in having tremendous impact in the world of nutrition. And this year we have Dr. Michael Golden, who was an emeritus professor of medicine and therapeutics at the University of Aberdeen. I had the real pleasure of meeting with him this morning, and we had some great discussions, although they ended up not being about nutrition as much as about educational initiatives and also ways to really have a broad impact. And Dr. Golden is going to be introduced shortly by Keith West, but he's really been a global leader in understanding and preventing childhood malnutrition, and his career has spanned 40 years. And he's really changed the way the world thinks about improving childhood nutrition and protecting and improving growth. And that came across to me this morning in our initially 30-minute, but then translated really to an hour discussion. So again, thank you very much on behalf of the school, and thank you for coming to give the 6th Graham Lecture. And Keith, if you would please introduce the lectureship.
Thank you, Dean Yeager, Dean Emeritus Al Sommer, Professor Bob Black, our guest speaker, Dr. Michael Golden, Dr. McLean, and honored guests, faculty, students, welcome. This is really a very special event each year. As Jim was saying, it's a time where we can bring in special speakers who are movers and shakers in the nutrition world. And the idea of this lectureship is to be provocative and to provide an opportunity to bring a different voice into our Hopkins public health community, and especially for those who are interested in nutrition. As Jim was saying, this is our 6th George Graham Lecture, and the 4th that has been endowed, and we're very pleased with and grateful to those who are supporting this lectureship, as Jim said. The lectureship is in the name of George Graham. George began the Division of Human Nutrition within the Department of International Health in the late 60s, early 70s, at a time when there was only one division in one department. So it's a mystery how this happens. You would think there'd be another division, but there wasn't. There was only one division in the department, and yet the department was a full-fledged department and functioning very, very well. George was a professor of pediatrics and international health. He also founded the Institute of Nutrition in Lima, Peru, which today stands as one of Latin America's premier nutrition institutes. He worked there for many years conducting research in malnutrition and its prevention and how to improve child growth. He had numerous appointments on the National Academy of Pediatrics, National Institutes of Health, American Institute of Nutrition, in which he was very, very involved, and gave numerous congressional testimonies in his own his own way. George had opinions that could not be swayed by anyone or anything other than evidence. And that often led him to be take unpopular stances against programs and ways that we do things from the U.S. government to the community in terms of how to improve nutrition. But it didn't matter to him. He looked at data, he interpreted data, he provided that interpretation to anyone who asked or didn't ask. It didn't matter. It's the evidence that always spoke for him. He was awarded the Joseph Goldenberger Award, the Borden Award, and other awards. He was a teacher. He was my first advisor when I came here back in the dark ages, in the 70s. He was an author of some 250 publications. This is just an example, a sample of Dr. Graham's publications and the kinds of things that he worked on, leading the Hopkins nutrition community, research community, and students, academic community, clinical community toward higher levels of understanding of malnutrition in children, what could be done about it. He was involved in defining the requirements for copper. He had an entire series that he published with co-investigators on infantile malnutrition that stand today as important contributions to the literature on protein quality and how children grow, don't grow, should grow, how we would want them to grow, what the roles of cereal foods are, a whole range of cereal foods that formed in many ways the basis of infant foods that are given to infants today. He was a very attentive investigator to the role of protein and nitrogen in relation to calories and how that has to be, those elements of the diet have to be balanced in order to promote growth, to the need for paying attention to digestibility and utilization of nutrients in the diet, and so forth. He carried out many studies with Bill McLean. Bill and George were an unbeatable duo in the late 70s through the 80s and into the 90s. They were a team that worked in Lima, Peru together, really defining the nutritional landscape for infants. So we're very pleased to have had George in Hopkins and to start our nutrition community and to have this lectureship named after his name. We do have a professorship. I have the honor of being the George Graham Professor, and so we are building a legacy in the name of George Graham. George can be seen there in these photographs. He passed away several years ago, but he was able to see the professorship start and the lectureship. We've had 5 before this. We had Ken Brown, who was a faculty member in the Department of International Health and speaking about food fortification. Bill himself gave the second George Graham lecture on how to use and observe in small studies detailed data that can tell you a great deal, as was learned in Peru. Our third was actually a mini symposium that looked at the interactions of nutrition and infection and honored the publication, the 40th year of a WHO monograph on this topic that was authored by our own Carl Taylor and Dr. Nevin Scrimshaw, and both there were 3 authors, John Gordon, who passed away a number of years ago, but both Carl and Nevin were here. We had a lecture on the effects of malnutrition on the risk of infection, and one on the effects of infection on malnutrition by Charles Stevenson and Claudio Lanata. Bob Black provided us with the vision forward, the way forward, which is not always clear, but he paved the road through a murky future, as always is the case when you're asking tough questions. And then we had a panel discussion by Dr. Scrimshaw and Taylor in their honor. So they sat here and badgered back and forth comments to each other, engaged in a discussion that you can see on our website for about 45 minutes and kept everybody spellbound. So we had some plaques for them just to give Michael an idea of the beauty of what follows your lecture today. We had Ricardo Wawi talk about linear growth and nutrition in a way that only he could do, a very, very dynamic speaker. Last year we had Andrew Prentice challenge us about mechanisms by which nutrition and infection interact, and how we have to know the mechanisms to understand the basis for public health. And this year, we have a giant standing on the shoulders of previous giants. So hopefully the floor is strong enough to hold all this weight, Michael. Michael will be speaking to us on malnutrition fundamental lessons when standing on the shoulders of giants. Michael is a graduate from Queen's University in Belfast. He was at the London School of Hygiene and Tropical Medicine, working with John Waterlow, who's a giant in nutrition of the past century, to work on nutrition problems. He quickly found himself stationed at the Tropical Medicine Research Unit in Jamaica, established by the Wellcome Fellowship, where he worked for 17 years, and including leading that unit on childhood malnutrition, infant malnutrition in its biological and nutritional context and its social contexts. Michael received in 1985 the Royal College of Physicians of London Award. He was on the Scientific Advisory Board of the Commonwealth Caribbean Medical Research Council. He was a chair. He had an endowed chair at the University of the West Indies in 1990. Following that, he joined the University of Aberdeen, where he chaired the Department of Medicine in Nutrition in 1993, chairing the Scientific Advisory Committee for a French agency, Action contre la Femme. And in the context of serving in all these positions, he developed methodologies for surveys. He is the inventor of food and ingredient recipes that have led to how refugees are fed today. The formulations that Michael established are ones that are followed across Africa and Asia today in terms of refugee feeding and how to promote growth. He is the originator of the concept of type 1 and type 2 nutrients that help us understand their metabolism and their function. He's been an advisor to numerous agencies, and I've probably said enough. So I would like to welcome Professor Michael Golden to the platform to enlighten us in the voice, as a voice of authenticity, I would say, in this field. So welcome, Michael, please.
Thank you very much, Keith. First of all, I would like to thank Johns Hopkins and the people that endowed the lectureship for inviting me here. It's a great honor to be here in this august company, in this august school. And I have met a number of you during the past few days, and I already feel that I'm standing on the shoulders of giants without going into history. So without further ado, I'll start, if that's okay. How do I get this to be me?
I think you've got my dregs up there.
Escape, isn't that right? Yeah. Stupidness.
That's right. Here, I'll get it for you. Don't let me get it for you.
Don't have a lot of... That's
Is that it?
That's it.
You don't want to talk about something else?
No.
Okay. Okay, here we go.
Thank you very much, Keith. Okay, firstly, some definition. I believe always in starting by defining your terms. I think that's absolutely critical. And I define nutrition that it compromises the processes by which dietary constituents, by which I really mean nutrients, are converted into and sustain the body, and how these processes determine the development, the composition of the body, modulate and control its function, and enable it to resist disease. And that's how I look upon nutrition, as a circumscribed subject. Of course, there are many other things, agriculture and food and so on, that feed into this, and anthropometry, anthropology, sociology, and so on. But this, to me, is the core of nutrition, the discipline of nutrition. It's really a branch of, if you want, in vivo physiology, in vivo biochemistry. And if you go back to the early physiology textbooks, there's large sections on nutrition in Starling's textbook of physiology, for example. It has an illustrious start. Liebig, Voigt, Warburg, particularly in Germany, and their students, Hans Krebs, Atwater was a student of Voigt, Neuberger, Schornheimer, Rittenberg, Ratner, and so on. All left Nazi Germany and brought their expertise to Britain. There were some British and American at that time, Cuthbertson and people like that. But I was particularly struck by Sir Frederick Garland Hopkins' Nobel lecture of 1929, when he said, and I quote, "Early in my career, I became convinced that current teaching concerning nutrition was inadequate." Have you heard that before? And while still a student in hospital in the early 1880s, I made up my mind that the part played by nutritional factors in the causation of disease was underrated. If that was true in 1880, it is even more true today. Everything causes disease except for malnutrition. And he, of course, worked on what was then called the accessory food factors from 1906 to 1912 and got his Nobel Prize in 1929. Then that led to really the first great leap, what I call the great leap forward in nutrition, where we have all these individuals dealing with the micronutrients, the vitamins, and of course we have E.V. McCollum here in the 1920s, which effectively founded this school. Okay, I'm not going to read through all the names. The second leap forward came with the Second World War, when your colleagues, your soldiers, your friends were incarcerated in Nazi and Japanese prisoner of war camps, and you saw your friends dying from severe malnutrition, and it really brought it to the forefront, malnutrition to the forefront of priority by the Western governments, the Allied forces. And during the war, Ansel Keys did his famous studies in Minnesota and went on to be a leader in nutrition in this continent. And R.A. McCance with Elsie Widdowson in the UK. Incidentally, Sir Hans Krebs was a nutritionist and did calcium balances in people during the war. But after the war, this problem was recognized and units were set up all over the world. Peru, of course, by George Graham, the person that we're honoring today. Guatemala, Scrimshaw, Thailand, Olson, Lebanon, McLaren, by the USA, and by in the UK, Jamaica, Waterloo, where I worked, Uganda, Rex Dean, South Africa, Brock and Gilman was there, Gambia, Whitehead, the Netherlands with Oomen, Belgium, Congo with Vis, and India with Gopalan and some other people. And all of these people, maybe with one exception, Gilman and someone like that, but virtually all of these people have given rise to students who are leaders of nutrition in Europe and North America today. I think the experience of going to the developing world and dealing with malnutrition and the realities of poverty that these leaders, these giants of nutrition, all of them, and the students that they bred, the scientific pedigree of many of us, including myself, owe everything to standing on the shoulders of these individuals. And we owe a great deal to the governments of USA and the UK for seeing the funds made available and the resources made available to allow these individuals to establish overseas units. Nutrition in the USA, nutrition in Europe would not be the same today if it hadn't been for the training offered to nutritionists by these units. I can't emphasize that anymore. And unfortunately, our leaders at the moment have lost sight of this completely, and we no longer are sending our young graduates to spend time studying these diseases in the developing world in first-class units, with one or two exceptions. Jamaica's still working, Gambia's working, Guatemala and Peru are working. So let me now turn to severe malnutrition. 1945, we had the concentration camps. Unfortunately, when the military went in and started to feed the concentration camp victims, there was an 80% mortality. These data were suppressed by Churchill because it was unacceptable to say that we liberated Belsen and Dachau and so on, and then we killed the inhabitants. 1956, the MRC units were established, and they used milk, oil, sugar mixes, basically the same recipe in the two places. 1960, potassium was seen as a major importance, and this was the work of present member of staff of this department, Georgia Lane, working with Garrow and Waterloo, of course. Montgomery saw the importance of magnesium. The Biafran War, I don't know why they used K-Mix 2, and it was still being used up until the mid-90s, and it's a miserable diet. 1976 developed a separate formula for the initial treatment. 78, zinc and copper requirements are calculated, added, and found to be effective. Other trace elements, 1992, 1993. The importance of acid-base balance was recognized. 1985, the type of oil and essential fatty acids became to the fore. 1986, changing it from per kilo to a diet, and that was an important step. And then 1987, bringing all these data together to formulate the F100 diet and testing it, refinement and rollout, and then the commercial production in 1993, and it was first used during the Rwandan, just after the Rwandan genocide. 1994, as I said, it was used in Rwanda. 95, because when Yvonne Grelity was looking at the problems of severe malnutrition from Adjumani and to Gulu in northern Uganda, and the LRA was kidnapping children, and none of the mothers would bring their children into the hospital to be looked after. The young babies with kwashiorkor and marasmus were just dying at home because the mothers stayed at home to keep their older children from being kidnapped. And she came back demanding a ready-to-use food, and which we developed in 1996. And it was the next thing, 1997, Bangladesh, ICDDRB, was developed from the draft manual which I'd written, Kachuri and Halva diets for the children, and they seem to be successful. André Briand then decided to, because he saw his children loving Nutella, to flavor the diet that we had with peanuts. And this was tested in Chad with extremely good results, and rapidly became used by nearly all the all the NGOs and the people working at the front line. 1998, Brion demonstrated that bacteria died within this product, and therefore it was safe to be used as home treatment. 1999, WHO officially adopted these as the standard treatment for severe malnutrition. 2000, there was further extension of treatment to outpatients by Steve Collins in Concern, and by 1994 he was spearheading the outpatient management of severe malnutrition. By 2006, it extended to treatment of moderately malnourished children. Then 2007, the lipid-based spreads were used to prevent malnutrition in Niger, and it has grown exponentially from then. Really, we're in the phase of a complete revolution in terms of the diets being developed for treating and preventing severe malnutrition, and it's just the start. I'll be talking about that later. So how our concepts have changed since the 60s. When I first started, kwashiorkor was thought to be due to protein deficiency. It's not due to protein deficiency. Breastfed children get kwashiorkor. Marasmic children don't have an old man face. The books are wrong. Marasmus is not usually due to energy deficiency. Marasmic children have sunken eyes when they're not dehydrated and they're salt sensitive. Most of the deaths are due to misdiagnosis of dehydration in non-dehydrated malnourished child because of this, and iatrogenic deaths, acute infection where there's a good diet. A good diet does not lead to malnutrition. Food security and nutrition security are entirely different subjects and should not be conflated together. And nutritional deficiency is now back in the center, nutrient deficiency of the etiology of malnutrition. And the UNICEF conceptual framework, I believe to be completely flawed and to lead to wrong policies for the alleviation, and wrong research, more important. So here we have 2 children breastfed severe kwashiorkor, and indeed 25% of children we look at in Africa with kwashiorkor are being actively breastfed, some exclusively breastfed. Well, here is a child. Child looks absolutely normal, doesn't look at the face, doesn't look wasted at all. You take the child's clothes off, and you see that the child is actually very severely malnourished. And because with IMCI, you've got 60 patients to see in 3 hours, that's 3 minutes a patient, we do not see any child having their clothes taken off, either to be weighed or examined, and most malnutrition is missed by clinicians because they don't look at the child. They look at the face, and the textbook which says malnutrition has an old man face leads to underdiagnosis, gross underdiagnosis of malnutrition in the field. Now, there are over 40 essential nutrients, and if any one is deficient, then the person won't be healthy. Each of the 40 is important. Selenium and riboflavin and pyridoxine are just as important, if you don't have them, as the more well-known nutrients, iron and iodine and so on. Many of these are ignored by doctors, and we've divided them into 2 groups. The first group, the type 1 nutrients or type 1 deficiency, are the functional nutrients, and the type 2 are the growth nutrients. And they have different physiology. The type 1 nutrients have a body store, reduced concentration in the tissues, specific signs of growth failure is not a feature, and variable concentration in breast milk, and almost the opposite with the growth nutrients. There's no body store, stable tissue concentration. You get the same signs with the deficiency of any of them, Growth failure is the dominant feature, and there's a stable concentration in breast milk. So if we see wasting and stunting, one of these nutrients which is deficient, and if we have non-functionality without wasting and stunting, it is this group of nutrients which are missing. And you can see that all the classic nutrients which are in the nutrition textbooks, which everyone works on, are the type 1 nutrients. Here, the vitamins and minerals. The type 2 nutrients, the growth nutrients, nitrogen, the essential amino acids, potassium, magnesium, phosphorus, sulfur, zinc, sodium, and chloride, have generally been ignored. And indeed, when things like CSB were being formulated, magnesium and potassium were almost deliberately left out. Kim Mickelson wrote a paper in The Lancet about this 30 years ago, and it had no effect at all, because everyone was hung up on just energy and protein. And we no longer use this term protein energy malnutrition. It's a complete misnomer. We should not use that term. Consign it to the waste bin. Severe acute malnutrition, if you want, it's lovely. Deficiency of any one leads to a deficiency of them all. Tissue repair ceases. The rapid turnover tissues are vulnerable, enterocytes and some of the white cell series. There's no convalescence from illness. You go into negative balance for one, you go into negative balance for them all. You get anorexia, and growth rate is the dominant determinant of how much of this nutrient you need and what balance of these nutrients you need. Here we have a favorite graph of mine, a child who was on a low zinc diet, and this is the growth rate. We put the child on zinc, suddenly puts on a kilo, 20% of the body weight in a week. Stop it, and immediately the growth rate goes back to zero. There's no store in the body for the child to call upon. And here we have muscle biopsies from a malnourished child, -3 Z scores, recovered to 100%, 0 Z scores, and a normal child. And you can see that the child's muscle has not recovered. And then we went on and did a study looking at the quality of the weight, the new weight gain of children when we added zinc, and this was the limiting nutrient, the limiting type 2 nutrient in the diet. And what you're looking at is the amount of fat the children put down, and the amount of lean tissue on the old diets and on the new diets. And you can see with the new diet, they didn't gain as much weight as this group, but they put on much more functional tissue and came back functionally to normal. So here are some functions which didn't recover. Thymus, delayed hypersensitivity, sodium pump, renal concentrating, glucose tolerance, muscle mass, and nitrogen retention. The nitrogen retention was a very seminal paper in my mind and changed my way of thinking, and that was done by Bill McLean, who's in the audience, and I pay tribute to you, Bill, for the work that you did in Peru with George Graham. Thank you very much. And this is the zinc, the delayed hypersensitivity increase in the supplemented arm. Now, we then went out to the refugee camps, and we started to feed children in therapeutic feeding centers. And each of these lines represents the mean rate of weight gain, cumulative rate of weight gain of at least 100, between 100 and 300 children on different diets. These ones, the top group, were on just F75, the formulation that I had designed. The ones at the bottom in the dotted line here were also on F75, but they had CSB or Unimix added to their diet as one meal a day. This is the diet which is normally used to treat moderately malnourished children, and when we fed it to the severely malnourished children who were on this balanced diet, it inhibited their rate of weight gain. I think this is an extremely good assay model, a bit like the growth of rats, and you alter the amount of nitrogen in the diet, and you work out, I don't add any more, and they maintain their rate of weight gain. And I think the severely malnourished child recovering or convalescing from their illness forms a growth assay system where we can look at diets and formulate them so that we end up with return of functionality as rapidly and return of weight as rapidly as possible. So I think the malnourished child is almost a dietary assay mechanism for designing new diets which will lead to rapid convalescence from illness. So we designed a diet, SP450. It was made from roasted oats and dehulled soya and a mineral vitamin mix. We used it in Rwanda after the war, after the genocide in '94. And the old diet was Unimix. And you can see that only 51% of the children given the Unimix recovered. On the new diet, 81% recovered. The important thing is the abandonment rate. 40% decided it wasn't worthwhile walking to get this diet because I didn't feel any better or my child didn't feel any better on that diet. And only 9% did that with the new diet. Okay. And this is the rates of weight gain on this oats, soya, mineral mix, and you can see it's 5 grams per kilo, which is exactly the same as people are now getting with Plumpy-Nut, with RUTF, which is about 6 or 7 times the price of the SP450. So what we did is we built a factory in Nairobi. We got the same nutrient mix coming from corn this time instead of oats, extrusion cooked instead of roasted, and using whole soya instead of dehulled soya, with exactly the same mineral and vitamin mix. And we tried that in northern Uganda and Somalia, and it didn't work. Absolutely no improvement in the rate of weight gain. So I then went and looked at anti-nutrients in these diets and weaning foods from around the world. What did I find? They're all full of phytate, antitrypsin, antichymotrypsin, anti-amylase, saponins, phytohemagglutinins, lectins, and so on. So I went to the Codex Alimentarius, and they told me to go away. So we have problem nutrients. Magnesium is a problem nutrient. Phosphorus is a problem nutrient. Zinc is a problem nutrient. Selenium is a problem nutrient. And when we do linear programming to try and emulate these diets, which lead not just to weight gain and fat gain, but also to return of functionality from mixtures of normal foods using linear programming, we can't emulate the same composition without giving some fortification or some supplementation to the local diet. So André Briand and people in the London School are leading this program of linear programming to try and get the nutrient balance right. But anti-nutrients is a thing which almost nobody's working on and is extremely important. So now in Maradi, in Niger, MSF France did a study where they took 12 villages and they had 6 intervention villages and 6 control villages randomly selected. They gave them, over the hungry period, here, blanket feeding everyone up to 2 years of age in the village. No, sorry, this study 3 years of age in the village during the black time. And this is the prevalence of the increase in malnutrition rate. And the control, it went up by 8% during the hungry season, and it really didn't change very much in the supplemented children. But this benefit was maintained for a year after this if the children were prevented from deteriorating during the hungry period. And in terms of stunting, the controlled children had increased stunting here, and the supplemented children had catch up in height. Now, what happened to the whole of the intervention area in Gudamunji? There's 65,000 children got a supplement of a thing called Plumpy Dose, and they really loved it. And here they turned up and queued up to get this thing because they valued it. And I think the abandonment rate, if someone abandons your program, don't curse them, don't say you're doing that. Look at your program. If people appreciate your program, they come. If your staff are kindly, friendly, and treat people well, and give them medicines which work, they will come and they appreciate it. If they abandon your program, you've got to change your program. Don't blame the people for running away. They are casting their vote. And here in Gudamunji, 62,900 people were enrolled and looked at in May. Only 20 didn't turn up in June, 57 in July, and so on. The dropout rate was less than the expected mortality rate in this society over that period. So if given that type of variation, the dropout rate could be said to include 0. And this is moderate malnutrition and severe malnutrition. New cases, this is the expected change in the new cases. So we expect it to more than double. And the red is the new cases of severe malnutrition. And we almost eliminated severe malnutrition with this intervention. Now, I want to tell you about this child because it's not just about nutrients. He's a very special child to me. An older child in Kimbanseke in the Congo. And I reckon I'm a reasonably good physician and pediatrician. The child wouldn't speak to me, wouldn't eat, wouldn't talk, and just lay there in the bed looking into space and was clearly going to just die. Unless we force-fed the child or did all sorts of heroic procedures. I was driving back into Kinshasa and I passed a little hut, and outside the hut they were selling things. There was a little football, plastic football like this, and I went and bought the football. It cost a few cents, drove back to the hospital, and I put the football here and said, this is a present for you. And I gave the child a kiss. The child didn't respond. This is the same child 24 hours later. There's 24 hours difference between these pictures. He was waiting for me to come back. It's probably the only time this child had had something of its own, only time it's had a kiss, only time someone had shown this child real love, that someone cared for the child. And I tell you that if you don't love children, you have no business being here. You have no business being a pediatrician. Go and become a pathologist and chop them up after they're dead. It is not, looking after children is not just a question of shoveling nutrients into them and designing programs to do that. It's a question of looking after people, loving people, and wanting to get them better. Never, never forget that. When I look at how the McDonald's staff treat a ragged, smelly drug addict who comes in for their hamburger, I'm amazed. They come in and the hamburger and the McDonald's staff says, "Good evening, sir. What can I get for you?" Big smile on their face. "Have a nice day. Here's your order," and so on. Why do our health service staff not treat patients in the same way? They treat patients as if they're dirty and they just want to use them as animals with tags in their ear to make money from. If you get it right, it doesn't only work for children. Here we have 4 weeks of feeding of adolescent, 4.5 weeks feeding, and this was on the old diet. You see, we've made her obese, woman. And to convert a child like this into this in 4 or 5 weeks, to me, is the essence of what medicine is about, the essence of what pediatrics is about. This child I want to pick up, I want to adopt, I want to love this child. And there's no downside to treating it. These children are not going to die if you treat them properly. Whether this child lives or dies depends on following a protocol, not diagnosing dehydration, not giving a drip, not giving a blood transfusion, not giving oral rehydration, not giving Rizamel, giving just F75 and then going on to F100, antibiotic cover, and being gentle with the child. This child survived, by the way, although you would think the child is quite sick. Where do I point this? And would you deny treatment to this mother? Would you? Why do we only treat children from 6 to 59 months in these programs? It's completely pejorative. Everyone that's malnourished within a family is important. The mother, the future mothers, the young girls, the children, of course, the fathers who are earning the money to keep the family sustained. And fathers, in my experience, love their children and look after their family. And it's the rare father who just drinks and gambles the money away. The poor have very few choices, and they're real experts at surviving with almost nothing. The results of very poor quality diets and no convalescence from illness, and this is a sort of typical encampment here with these huts, with each hut crammed with people, and they are scratching out a living with almost nothing, and I don't know how they do it. Designing a program for these people requires much more than just sitting here and saying we're going to educate them and we're going to give them this food and we're going to give them that and we're going to give them some mosquito nets and so on. A much greater threat is political disaster. And here we have a child soldier in Sierra Leone and so on and so forth, a poster for recruitment for Savimbi in Angola that I took, and we see the horsemen of the apocalypse coming, and war is the harbinger of great famine and malnutrition at a really heroic scale. As it was during the Second World War, we're still getting wars all over Africa at the moment, coups and so on, and there's massive malnutrition there. It is not only in stable, poor countries that you find malnutrition. It is much worse when you have civil strife. And of course, you have all the type 1 nutrient deficiencies as well. And that adds to the burden of death with malnutrition as the cause. Now, somewhere between a third and a half of all deaths are related to anthropometric malnutrition, which is type 2 deficiency. And to that, we've got to add the deaths from type 1 deficiency. So much more, many more than half of all deaths have malnutrition as the underlying cause. And we treat our medical students so badly that we will give them 1 or 2 days training about malnutrition out of a 6-year course. They know more about the Wiskott-Aldrich syndrome or the 5 and 3' end than they do about malnutrition. We are letting down the human race in our curricula and the way we treat and teach medical students and nurses. And of course, how can he provide for his family? Adults who are malnourished are also important. And the problem with the HIV epidemic is it's killing off the breadwinners and the adults. We have child-headed families now, and we have a tidal wave of orphans. When I was in Harare, in Bulawayo, I wanted to teach on the malnourished child. I said, where's the mother? Oh, go and get the mother. The team went and found one mother with 19 children to look after, a grandmother. All her 6 children were dead and had left the grandchildren with the grandmother. She had 19 children to look after and no visible means of support. The children were nearly all HIV negative, but they were all going to die from malnutrition. Now, the epidemiologists here. Many of my friends have died. No one seems to care. Sometimes epidemiologists come and ask us questions, and then we become statistics for international politicians to argue about. Occasionally, WFP comes and gives us maize, beans, and oil. And I get so angry that these surveys don't lead to any meaningful intervention usually, and I go around and see this type of a problem wherever I go in Africa. The response is pathetic. Tens of thousands, hundreds of thousands of people, not just children, are dying from malnutrition, and all the money is going into HIV. And we have people now who are deliberately trying to get HIV so that they can access free health services. Those that rule us or do fight or exploit us are the main cause of my misery. Again, this child from Bor in Sudan survived. This one here is being robbed by soldiers. The malnourished person is there, and the soldiers going through the pockets and the clothes to try and get the money from the malnourished child or the malnourished adolescent. We were actually quite lucky to get the photograph without being... But we're still not sure of the cause of kwashiorkor, and I wanted to tell you about some interesting new findings. Firstly, this was in the Lancet. This is a marasmic child's glomerulus, that's the basement membrane, and here we have the space of Dis, and this is the podocyte here, and this is the same on a kwashiorkor child. And it's the same electron microscopic appearance as minimal change nephrotic syndrome, and yet the children do not have albuminuria. So I thought about this and considered that perhaps the surface charge on the membranes here were actually keeping the membrane apart and stopping it from fusing. And this could be a problem of the glycosaminoglycans, which are the complex carbohydrates which have sulfate charges, negative charges all over them. So what I did is took the 2 kidneys out of a child that had died and perfused one with saline and the other one with heparin sulfate, and then took repeated biopsies from these ex vivo perfused kidneys. And by perfusing heparin sulfate through the kidney, we were able to restore the normal electron microscopic appearance. Putting glycosaminoglycan abnormality rarely at the center. So the next thing we did is got biopsies from Lusaka in the Zambia, and we stained them for sulfated glycosaminoglycans, heparan sulfate, proteoglycan, and syndican-1, which is the core protein, to find out whether there's a problem with protein synthesis. And you can see that there was no problem at all. This is the kwashiorkor children. These are the normal ones. There really was plenty of staining. The brown staining is the staining we're looking at of the core protein. But heparan sulfate was almost absent from the villus, and sulfated gags, again, were almost absent. If you have a congenital problem with these, you get intractable diarrhea. And there have been a few cases described by Simon Murch and others of congenital abnormalities in Golgi formation and glycosylation of the intestinal heparan sulfates. And these patients have protein-losing enteropathy and intractable diarrhea. So I think this is really quite interesting. But does it make any difference? Does it all this make any difference? Actually, the glycosaminoglycans sulfated are incredibly important for the blood-brain barrier. They maintain the blood-brain barrier. And any drug which passes the blood-brain barrier and becomes toxic, you should not give to a child with edema. Any of you who are involved with an onchocercosis program, under no circumstances give ivermectin to any edematous patient. Okay, so we changed the protocol, and we're now up to version 6 of the protocol, and we didn't do a controlled trial. This is a before and after trial. And this is with the old protocol in Kimbanseki in Congo, just beside Kinshasa, high HIV area. And this was the mortality using the standard WHO protocol, 12%. There's about 200 children in each arm. After that, we had 1 death out of 200 with the new protocol. Overall, with the kwashiorkor, 17% before, 3% after. And these are the expected deaths using the Prudent algorithm for expected mortality rates, trying to adjust for the severity of the illness amongst these two groups of children. So we are making progress. At the moment, about 250,000 children, 250,000, are being treated in Ethiopia every year with about a 2% mortality. Burundi, about 30,000, Rwanda, 20,000, and we can go through all the countries of West Africa. And you add them all up, in Africa alone, more than 1 million children are being treated for severe malnutrition today, each year, with a 2 or 3% mortality rate. The mortality rate used to be 30% for severe malnutrition for patients admitted to hospital. So we've a long way to go, but we're making enormous strides. And the coverage and finding children in the community is now dramatic. So I come back to what Winston Churchill said during the latter part of the war, before the end of the Japanese conflict, but after the end of the Nazi conflict. He got up in the Houses of Parliament in the British Isles in England, Westminster, said, "There's no better investment for this country to make than to put good food in the mouths of its babies." We now have a much better understanding of what's meant by good food. It's nutrient security, not food security. It is not just empty calories to make you fat and empty protein or even 2 or 3 selected micronutrients. It's a proper, diversified, balanced diet with all 40 nutrients in there in the right amount, even if some of them might need to be fortified or supplemented, like the Swiss have been doing with iodine in their salt for many years. That's why they're no longer Swiss gnomes. There's now a massive research agenda to get the right nutrients and the right quantities in the right balance into the mouths of babies sustainably and at a reasonable cost. The answer is not plumpy dose or plumpy nut or plumpy anything, RUTFs and RUSFs. They're expensive. The logistics is difficult. They need a trained staff to give them out and to weigh people. It is not the answer. But what we've done is put nutrients and the provision of available nutrients back to center stage of the causation of malnutrition. And now there's a research agenda to find out how we can give them to babies sustainably. Okay. I've gone on a bit long, and this is my last slide, thank goodness. I'm going to show you a short video. The last thought I have is, if you know and understand malnutrition in all its aspects, then you know the whole of medicine. You know the biochemistry, you know the physiology, you know the sociology, you know the public health. In fact, you know everything. And I really firmly believe that's one of the reasons why the giants whose shoulders I've stood on and their pupils are such good clinicians, such good observers, and can go into almost any branch of medicine after they've been trained in looking after the malnourished child. And not only go into any branch of medicine, but excel in that branch of medicine. And I think the future of American medicine not only depends on the 3 and the 5 prime end and the molecular biologists, even though their advances are startling and very dramatic, and will almost certainly contribute to the third revolution in nutrition. No, I don't know how to get rid of this. Oh, here we go. Let me just play this for you. And the reason I want to play it... Okay.
Yeah, it's working.
How do I get it big? Yeah.
Ah, c'est fou, hein?
Stop. The child with kwashiorkor in the Central African Republic. Do you want me to play it again? No, I don't think so. What do you think that child's neurotransmitters are doing? What do you think its blood-brain barrier is doing? What's getting across the blood-brain barrier? Why is its brain behaving like that? That child has catatonia, exactly the same as you would describe in a schizophrenic with schizophrenic catatonia. Now, when I show this and talk about this, clinicians say they've never seen it. Yet I see it in about 10 or 15% of the kwashiorkor children I look at. The clinicians have never tested for it. That's why they don't see it. There is such a lot to learn in terms of fundamental physiology, fundamental toxicology, biochemistry, neurology, from the model of the malnourished child, which is applicable to the patient with cancer, the surgical patient, the patient with GI disease, the elderly. There is an indivisibility in science. And to study the malnourished child and bring that child back to normal, I can think of no greater good that a clinician can do, both from an intellectual and a scientific and a humanitarian point of view. Philosophia, philotoknia, philanthropia. Thank you very much.
Thank you, Michael. We have some time for questions. We have some microphones. I'll start it off. Put it on. So I think a lot of the research nowadays is trying to get to the headwaters before we get to the kwashiorkor or marasmic infant through the conduct of proper feeding of infants as they transit from exclusive breastfeeding to a complementary feeding diet. What are your thoughts in terms of the utilization of these formulated foods as opposed to or alongside locally composited complementary type foods? Where should we go with that
I'm sure.
design?
I'm quite sure the future is from locally composited foods. To test them and to test them properly, we need a gold standard. So you've got a standard against which you can test the various formulations. I actually think that the recovering severely malnourished child is a very good, if you want, assay system. When I started to do this work, I was absolutely astounded to do work on children and have students from Texas A&M confirming my findings in rats. It seems to be the wrong way around, doesn't it? I mean, we normally do rat models to give indications of human disease, and I was doing experiments in children, and the students in Texas A&M were confirming what I was doing in children and rats. Rats are fairly naive human beings, and test tubes are even more naive human beings. If we're designing diets for human beings, we should be testing them on human beings. So we need an ethical model that we can use to test these diets. And either the convalescent child, convalescing from acute diarrhea who's lost weight or something, or the severely malnourished child, or even the moderately malnourished child, I think we can use in small efficacy trials under metabolic conditions as an assay for testing diets incrementally until we get a formulation which seems to really work. And then we can go to large-scale efficiency trials. I don't think we should go to efficiency trials before we have the efficacy trial. But yes, we want every child to get the right nutrients into their mouths in an available form. But 40% of the world's children are stunted. I mean, it's an enormous problem. It is a massive problem. And they end up mentally deficient and not fulfilling their potential and all sorts of things. I can't think of any problem which is more important to the world today, certainly in terms of development. And in terms of all the other programs, they're more susceptible to death, they're more susceptible to disease. As I said to someone today, when I was young, I had measles. And I enjoyed my measles because I got 2 weeks off school. I didn't really like school. And all my friends from school came to visit me to try and catch measles from me so they could get 2 weeks off school as well. If an African child gets measles, he dies. What's the difference? And the difference is I had a good nutritional state, was able to resist disease, get over this thing really quite rapidly without any problems. The African child gets all sorts of complications and ends up dead from their measles. And you put the death down to measles. You may as well put an HIV death down to pneumonia. It's the same thing. The child would not have died if they hadn't been malnourished. So we are undervaluing it, and we're undervaluing it, as Hopkins said, right from the beginning, because we're not training medical students. There's no funding for it. There's really very little expertise for it in the medical profession. Because of that, people are not happy to examine on it. The questions aren't asked in the exams. The students don't learn about it. They go into the wards. They make all sorts of terrible problems. You have a patient with carcinoma of the breast, for example. Sorry, it's a long answer to your question. You know,
I'm sure you're going to end up back on children.
You squirt them with radiation, or you give them, no? and they get pneumonitis and skin burns and all the rest of it, and you say, I'm awfully sorry, too many complications, we're going to have to stop your breast cancer treatment. And the patient dies. Why? Because the normal cells don't have the antioxidants, the glutathione, the vitamin E in it to protect themselves from the radiation. And when I was in Jamaica, did lots of things which was interesting. We started to treat the malnourished leukemics with these types of diets. And unfortunately, we were feeding the leukemia, and the white cell count went rapidly very high because the leukemic cells loved all these nutrients. They thought it was wonderful. But of course, when you think about it, that can be used. Nutritional manipulation of the metabolism of the patient can be used to put all the cells into mitosis so that they become radiosensitive and chemotherapy sensitive. I mean, to not use the lessons that we're learning from the severely malnourished child in all the other branches of medicine is almost criminal. In the surgical wards in Jamaica, I used to do skin biopsies in the axilla for all the cold patients. And we used to throw the biopsy away, and we used to look at the little hole that was made to see how it healed. If it didn't heal, we would say to the surgeon, for goodness sake, don't do a laparotomy in these patients and start chopping their guts and bits out because you're going to get wound dehiscence, secondary infection, the fistula formation, and all the rest of it. I will treat them nutritionally and get them back to a good nutritional state. Then you can do your surgery. Suddenly we had no wound dehiscence, we had very little wound infection, we had no fistula formation, we had nothing like that. Why? Because we tested for nutritional status, functionally, how well they healed, and we treated it. And, the surgeons, the gynecologists, the obstetricians, the neurologists, everyone should know about the effect of malnutrition on the metabolism of the drugs they give, and so on and so forth. So I can't be more dramatic. It's in the medical profession's own interest to do this. And it's in its own interest to maintain and establish units like George Graham's unit in Peru, and to send the young, bright doctors down there to do their MDs and their PhDs with the patients in the developing world. And that will train them to look after the patients in Baltimore. It is not a waste of time or a waste of money.
Did you get your answer?
Sorry. Please forgive me for...
That's okay. Do we have any other questions?
No, he didn't get an answer. I don't know what the answer is.
I guess that you did answer it. You got to those local foods.
Yeah, it is local food.
The local foods need to be tested.
But there's a way to get there.
Yes, yes. Any questions? Any other questions? Because we do have a plaque to, well, I don't want to, it's a surprise, so I can't tell you. Okay, well, I would like to thank you very much, Michael. I would also like to welcome Alec Graham, who I think you got here just as we were finishing maybe the intros. Alec, thank you for coming. We appreciate you having you here. So, Dean Yeager, you have a job? Yeah, you do. And there are very few people who have something so gorgeous. Bob, don't show anybody yours. So, if you hold that, please. This is a plaque that has been hand-hewn in a village in northern Bangladesh. Everything is handmade, even the brass. It says, the 6th George G. Graham Lectureship. Michael H.N. Golden, University of Aberdeen, for excellence in improving child nutrition, April 19th, 2012, Johns Hopkins University Bloomberg School of Public Health, Baltimore, Maryland. Malnutrition lessons standing on the shoulders of giants. Welcome, and thank you.
Thank you very much. Congratulations.